Hello, my name is Patrick McCulloch, and I'm a professor of clinical orthopedic surgery at Houston Methodist Hospital. And today I'm going to be talking about an exciting research study that we have ongoing using mesenchymal stem cells, or MSCs, as a surgical adjuvant for patients undergoing ACL surgery. So for those of you who are not sports medicine doctors, ACL stands for anterior cruciate ligament injury, and that is one of the most common knee injuries that we'll get in playing sports. So typically, it's one of the four main ligaments of the knee, and if it tears, it has very limited intrinsic healing potential. So that's why it's a target then for potentially doing a surgery to reconstruct the ACL. The injury mechanism is typically a cutting or pivoting mechanism that causes a pivot shift phenomenon. So the leg comes forward, the bones knock against each other, and the ACL is torn. You get bruises on the bones. Anything that lives in between them, like the posterior horn of your meniscus, can get torn. And so the symptoms then are pain and swelling and instability, right? Okay, but we have a great operation that can go in and reconstruct the ACL and make the knee more stable. But the sequelae of ACL injuries is not insignificant, right? Because initially, we have what we call the macroscopic damage, right? So it's a torn ligament, right? It's bruises that we can see on the MRI in a very typical pattern related to the ACL injury where the bones knocked against each other. What happens to that cartilage that's been bruised? What happens to that underlying bone? Well, there are also then microscopic changes which happen. And so that often leads to inflammation. And inflammation can then lead to what we call apoptosis, or programmed cell death. So we've got the initial injury, and then we get a whole second wave of injury. And we know that even though we can get you back to playing tennis and get you back to skiing, 20 years later, a significant percentage of these patients will have osteoarthritis, or what we call post-traumatic arthritis. So when we look at MSCs, we think MSCs might be able to help with both the healing and to mitigate some of the injury, right? And that's because MSCs have the ability, and this is sort of the definition of what a stem cell is that they can regenerate. So one can become two, right? So it's a population of cells that can help with homeostasis, that can help with repair, right? They also have differentiation capabilities. So one stem cell could become two progenitor cells that then also divide and become more cells. And now we can have these cells that go along different lineages, and they can become bone, tendon, ligament, cartilage. So this is what we call the lineage of a stem cell. And so one stem cell has the capability of helping us with all of these tissues, right? And when this was all first sort of discovered and described by Arnold Kaplan, in his seminal paper in 1991, he proposed that the ability for them to turn into all of these different tissues makes them a very good target for cell therapy. And that remains true. However, they also help to create new blood vessels, which is another part of healing. And the main thing they do, perhaps, is to regulate the response. So Kaplan himself later said maybe these MSCs should be called medicinal signaling cells. Okay? So we still have MSC, but he thought this was a more apt name because of what they can do. Because they can activate local cells, they can recruit new cells to the area, and they can direct the response, right? And they can direct that response with what I call the 4 antis, okay? Because they're anti-inflammatory, anti-fibrotic, antibacterial, and anti-apoptotic, meaning they can limit some of that programmed cell death, right? So we get the local cells activated, we bring new cells to the area, we keep cells from dying, we have all these other properties that we love as surgeons, anti-inflammatory, anti-fibrotic, antibacterial, right? And so originally it was thought that, hey, these cells, you can get more and more of them as they regenerate and they turn into all these tissues. But it seems like maybe the biggest benefit of them is what they're directing the other cells to do. So we always thought about them as being the soldiers that come in and do all the work, but maybe the better way to think about them is the general at the top that's directing all the troops to get the job done. So when we look at different sources, here we got to talk about the FDA, right? So the FDA allows minimally modified tissues. So one can take fat and micronize it and inject that back in. One could take a blood product or bone marrow and spin it down in a centrifuge and put it back in. And that's allowed because that's an exception, but from the FDA for minimally modified, okay? But in order to meet the FDA's rigorous standards for a true cell therapy, then if you're going to culture cells to get more of them, then that needs to be done in very specific conditions, and it needs to be approved by the FDA. Okay? So using allogeneic tissues that have cells in them, that's not the focus in our lab. We're talking about using the patient's own cells and growing them, right? So they're present in all tissues, but they're present in different numbers. So we have to figure out which tissues we want to use, and they don't all have the same regenerative potential, right? And then they're really small numbers, right? So if we look in bone marrow, for example, which is something we've studied a lot and we considered for one of our sources, well, 0.01 to 0.001% of the cells in bone marrow are actually MSCs, okay? So it's a very small number. So if we want to take bone marrow and we want to grow those cells where we have a sufficient number for an FDA study, then we're going to need to do a lot of culturing for that, right? And this is work that we've done in the lab. And so when we were preparing for this study, we cultured a lot of these different tissues. So metabolic fat, bone marrow, and Hoffa's fat pad, right? So they all have different regenerative potential in terms of their potency and how quickly they will grow, right? So when we're looking at a source of MSCs, we want it to be easy, right? So ease of access, right? So if it takes a big procedure or it's difficult to get, that's challenging, right? We need a high initial number of cells, because if we're going to have to culture them, well, if we start with a really small number, it's going to take longer to culture them, right? And then we need to have a high potency so that they actually can do what they need to do, right? And so we have found that when we looked at bone marrow or synovium or other tissues, the best growing ones for our purposes come from the fat pad, what we call the Hoffa's fat pad. So here we have our torn ACL, okay? And so at the time of surgery, when I have this camera in doing arthroscopy, I have access to this fat pad and can take a sample of that, right? And in fact, removing some of the fat pad just for visualization is often a part of ACL surgery. So we found that the number of initial cells, the doubling time, so how long it takes to get double the number, which we call the doubling time, and the potency, were all better on our early passages with the fat pad versus the bone marrow. And in fact, when you look at fat pad compared to metabolic fat pad does way better, and that's because metabolic fat has a function, and its primary function is insulation. Whereas the fat in the knee, actually its primary role is homeostasis, so maintaining a healthy joint. So not all stem cells are created equal. Sometimes they have more potential to do what you want them to do, and we found that the fat pad was particularly good. So for this study, which is now enrolling, the harvest is done at the time of ACL surgery using a shaver and a commercially available tissue collection device. We then take that fat and we digest it, because we want to take fat and turn it into cells. Those cells then need to be sorted, and they're sorted using a typical fluorescein antibody cell sorting machine so that we can separate out just the MSCs, and we want to isolate them and make sure that they're MSCs. And that means we're looking for certain cell surface markers. So to be an MSC, it has to have certain cell surface markers. It has to lack other ones like immune cells would have, for example. It has to be adherent to plastic, and it has to be able to differentiate into bone, cartilage, and fat. So once we know we have MSCs, then we expand them. So we grow them to get 50 million cells. And we do this in a cGMP facility that we have here at our hospital. And so that means that we'll have a large aliquot of cells that then we can put back in. As to what's the right number to use, well, this is based on some previous studies from Korea and Japan and China, and we don't know whether it's the exact number, but that's one that we're trying to replicate based on prior studies. Once they've grown to 50 million, then we want to do confirmatory tests to make sure that they're viable. And that they have good potency. And then we do the delivery. And the delivery is going to be an ultrasound-guided injection into the knee. So this is happening then 14 days after surgery. Good. And what are the questions we're looking to ask? Well, for early FDA studies, the main question is, hey, is it safe, right? And we want to make sure patients aren't having complications. We also want to know, does it work? Because a lot of patients will hear about this in the media, and they hear about going to other countries to do it because it's not legal from the FDA standpoint. It hasn't been approved. Well, I think the role of people in large academic centers is to do the work that help to answer these questions. In this study specifically, we're going to look at pain. Because it's anti-inflammatory, we're hoping that we'll see decreased pain, and that's been seen with injections in other joints. We're hoping that it will decrease swelling, right? It's also anti-fibrotic, right? So it may help with range of motion. We're going to look for complications. We want to make sure that they're not having undue reactions from the injection itself. And then we're going to look at healing. We want them to have a normal ACL exam. We're going to look at their functional scores, right? Like objective jump tests and what we call their return to play rates. And then we're going to look at other secondary things. Like, for example, when they've torn the ACL, well, we may be able to give them a great new ACL that allows them to go back to skiing or allows them to go back to tennis. But what about this cartilage? Are we seeing wear on the cartilage over time? And that's one of the things that secondarily we can look at healing of the graft into the tunnel. We're usually taking a tendon, right, and we're making that tendon become a ligament, so we're looking at ligamentization. And then we're also looking at markers of cartilage thickness and health on our follow-up MRIs. So this is a study that's presently enrolling, and we hope here at Houston Methodist that this will allow us to treat our patients better, or at least answer the questions that all of us orthopedic surgeons have about the future of our patients.